Good evening, everyone, and welcome to day 3 of our online oncology days. My name is Maarten Groes, Clinical Research Manager, and on behalf of Canon, I am delighted to bring you this session focused on lung cancer screening. Welcome back to those of you that joined us during the previous days. But don't worry if you have missed that. All sessions are recorded and will be available online in about 2 weeks on the Canon Medical Europe website, so you can go back and check it out. This evening, the session is about lung cancer screening, a super hot topic, and therefore we are very delighted that we were able to line up this exceptional panel of speakers for you. It gives me great pleasure to introduce our moderator and first speaker of this evening, Professor Cornelia Schäfer-Prokop. Professor Schäfer-Prokop is a radiologist at the Meander Medical Center in Amersfoort in the Netherlands. For her research activities, she's affiliated with the Radboud University Medical Center in Nijmegen, also in the Netherlands. Her main research interests are in computer-aided detection and classification, lung cancer screening, and interstitial lung diseases. She's currently the president of the Fleissner Society, and we are very happy she's here as the moderator and first speaker of the day. So, Professor Schäfer-Prokop, thank you for joining. Today's session is yours.
Thank you very much for this very friendly introduction. It's an honor for me to be the first speaker on this webinar. And I will try to set a base for the following speakers with the title Lung Cancer Screening, Where Do We Stand? This is the disclaimer that the options expressed in this material are solely those of the presenter and not necessarily those of the Canon Medical Systems. How big is the problem of lung cancer? It is the second most frequent cause of cancer and the leading cause of cancer deaths worldwide, with more than 20% of all cancer deaths, exceeding the sum of breast, prostate, colon, and pancreas cancers. The survival is heavily dependent on the stage. As earlier as we defined it, as better is the prognosis. This is a summary of all the studies which have been done within the last 20 years. And if we start here, there are a number of European studies, the Dante study, DEPISCAN, the Danish trial, 2 different Italian trials, a German trial. But the summary of these trials were that non-significant reduction of lung cancer-related mortality. Most likely to the fact that all of these studies were actually not statistically significant, just the studies were too small. And we all know that there were 2 very big randomized trials, the NLST trial in the United States and the Dutch-Belgium Nelson trial. Both have been published and both actually showed a significant reduction of cancer-related mortality. And I will go a little bit more into detail into that. This is the summary of the National Lung Screening Trial. And we do see what they did. They compared low-dose CT with chest radiographs. More than 50,000 subjects were included. And it's just not only that they found more lung cancers in the low-dose arm as compared to the chest radiograph arm, but they also found, starting slowly but increasingly, a discrepancy between the 2 curves here. They found 20% fewer deaths from lung cancer, and that was actually the goal of that study, which could be closed even earlier because that was happening earlier than the original plan. This is the summary of the Nelson trial, which actually is a very similar curve. They included many more men than women. Therefore, these are the curves for the men only. And we do have the control arm and the screening arm. And they actually found a reduction of 24% lung cancer related deaths in their study. So this was also significant. So these 2 big trials actually provide the evidence lung cancer screening does work. And that led already in 2015 to the fact that, especially in the United States, based on the NLST trial, many professional societies, such as the American College of Surgery, College of Chest Physicians, and so on, recommended and endorsed a screening. There are also an increasing number of international societies, also societies in Europe, who actually recommend screening. So what else did we learn besides the fact that they can achieve significant reduction of lung cancer-related mortality? These are results from the Nelson trial, and we compare here what has been found in the males and in the females. And I said already that there were less females included. But you do see very easily between here after 8, 9 years, 10 years after inclusion, that there was a big discrepancy between males and females, with a much higher reduction of lung cancer related mortality in the females as compared to the males, almost more than double, for example, after 8 years. And this is actually a finding which is seen also in the NLST trial, also in the Nelson trial, and also in the Lucy trial, that lung cancer related benefit is bigger, much bigger in the women than in the men. Why is that? If we see here in the control arm, then we see that in the men, the distribution of cancer types is much more diverse as compared to the women. Here, the vast majority are adenocarcinomas. And if we go to the screening arm, then we see that the selection is even getting more pronounced in the women. We have almost exclusively adenocarcinomas in women as compared to a more diverse part of cancers in men, and adenocarcinomas have a better prognosis as compared to small cell carcinomas or squamous cell carcinomas. If we look at these data here from the German Lucy trial, then we do see that both advanced stages and low stages increase in the screening arm. But if we especially look at the relative stages over here, then we see that the relative number of early stages is much more impressive as compared to the advanced stages. So what we see is we see more high stage and more low stage cancers. They have been found, but relatively there are much more low stage cancers. So what we learned besides the evidence is that lung cancer screening has a greater benefit in women. It detects mainly adenocarcinomas, and it brings forward early disease. How long should we screen? If we here look at the years 1, 2, 3, 4 after inclusion, then we see that in the first years, we have almost the same number of advanced cancers in the screening arm as compared to the control arm. And only after, let's say, the third year after inclusion, we do see a discrepancy with less advanced stages in the screening arm. And only then we have the chance that we have a decreased rate of mortality, which is nicely seen in these curves. The first years after inclusion, these two curves are going more or less parallel, more together. And only after a while, we see a discrepancy between the control arm and the screening arm. So we do see the advantage of cancer-related mortality reduction. And this has been seen in the Lucy trial, as well as here in the NLST trial. So the effect kicks off only after round 2 or 3. This is also shown by the long-term follow-up in the MILD trial. I remember you that after 5 years, there was no significant reduction in mortality in the MILD trial. And then they published more results after a 10-year follow-up. And after 10 years, you have a greater chance that these two curves disappear. They have a larger difference between. And actually, after 10 years, they could find a significant reduction of lung cancer mortality. So prolonged screening beyond 5 years can enhance the benefit of early detection and achieve a greater overall and lung cancer mortality reduction, even compared to the NLST trial. So that brings us to the question, how long should we screen lifelong? And then if you see here these curves, there is a huge discrepancy, but then they come closer together again, closer and closer, and after a while they go parallel. The same is actually here seen for the lung cancer mortality. This is lung cancer incidence and this is lung cancer mortality. So we see a discrepancy, that is what we actually want to see. But after a while, and this is about 2.5 years in one trial and 3.5 years in the Nelson trial, they are going parallel. So what we can conclude from that, should we screen lifelong? The USPSTF in the United States recommends an annual screening up to 80 years. But they also advise screening is not advised for those with limited life expectancy due to significant comorbidities. The point is that with an increasing age and with increasing numbers of years after inclusion, there is a competing risk between lung cancer on one side and competing other comorbidities. Screening interval, should we do it annually or should we do it biannually? There is actually not much evidence up to now. The NLST trial was annually. The Nelson trial was the only one who also evaluated the 2.5 years interval, which actually lead to a significant increase of interval cancers. And the MILD trial, the Italian trial, was the only one who did that in a structured way and found that there was no significant difference in mortality between annual and biannual screening. But we have to say that this is not yet the final answer, and there are some kind of model calculations and ongoing studies which still evaluate what is the ideal, maybe even personalized or individualized screening interval. What is the target population, what we are looking for? The problem is if we only go for heavy smokers, it's kind of a stigmatization by the society. It's the only cancer blamed on patients. The problem is 20% have never smoked and 60% are former smokers. The target population is the eligibility, and the target population is a very crucial factor for the cost effectiveness and the overall effectiveness of the screening. So these are a lot of numbers, but the summary of these numbers is, and this is what we know, that with increasing history of smoking, there's an increasing risk for developing lung cancer. So in other words, screening 60% of the highest risk groups prevents 88% of the lung cancer deaths. So it did make sense in the NLST trial and in the Nelson trial that they included heavy smokers. On the other hand, if we look just at here, the screening criteria, age 55 to 80, more than 30 PEC years, would be met by less and less and less lung cancer patients. If we go here, look, these are lung cancer incidents in these time intervals, and you see going down, that less and less patients who developed, in fact, lung cancer would have met these eligibility criteria. So there's room for improvement. There are a number of risk estimation tools which can be used, and some of them only use age and smoking, as has been done in the NLST and the Nelson. But other trials, for example, they use more complex one, the PLCO or the Liverpool, and they actually have a much better effectiveness, as you can see here, 8.8 fewer people, but 12% more cancers. It does increase, for example, what they include, not only age and smoking history, but also education, personal history of cancer, COPD, BMI, race, and so on and so on. So the eligibility becomes more effective, but also more complex. The last what I want to mention is that the eligibility criteria in the US have been changed. They went down to a younger age, to 50, to less risk, from 30 PEC years to 20 PEC years, actually to also take into consideration that, for example, in the Black population, they smoke fewer, are diagnosed younger, and have a higher risk of dying, to decrease this disparity between different subgroups in the population. In summary, there is sufficient evidence that it works in women better than in men. There are some racial differences. There are some open ends yet. Criteria for screening eligibility, screening interval, maybe individualization, when to stop, talking about the competing risks, how to increase screening uptake, and some administrative challenges. Cost effectiveness is directly related to prevalence of lung cancer, cost of low-dose CT for screening, proportion of the early lung cancers, and combination with smoking cessation. And individualized follow-up, high throughput screening, and optimization are the clue for cost reduction. Thank you very much for your attention. So after this first talk, it will be my pleasure now to introduce the next speaker, who is Professor Hazard Jenkins from the West Virginia University School of Medicine. She has been trained in the WVU School of Medicine, later on in Chicago, and she's Associate Professor of Surgery. She has been the assistant to the Dean for Admissions, followed by the Cancer Service Line Director, and now she is the current Director of Director of the WVU Cancer Institute, with a mission, and that is actually the topic also of her talk, to bring screening to also more rural and distant areas. And with that, I want to give the word to Professor Hazard Jenkins.
Thank you very much for having me, and it's an honor to be able to present some of our work. So I give full credit to our cancer prevention and control team here at WVU, and it's an honor to present the work that they've been doing over the years. For me, it's a very important thing to explain who we are, because in doing that, you'll be able to understand why we did what we did. West Virginia is a small rural state. About 65% of our patients actually live in communities less than 2,500. And so we're dense, we're not densely populated in any fashion. And you can see that in order to travel from north to south, it takes about 7.5 hours and only slightly less time to go from east to west. Our largest city is only about 50,000, but on any game day in the fall here in Morgantown, the stadium actually holds 60,000, so the stadium becomes the largest city. And I say that in the context of understanding what it takes to travel to get healthcare, let alone getting risk reduction and screening. And so our focus has been on figuring out innovative ways to deliver healthcare to some of these more rural populations. We do have quite a bit of success with an additional rural mobile program. In 2009, we started Bonnie's Bus. This was in memory of a benefactor's mother who died of metastatic breast cancer. And through partnerships from the Cancer Institute and WVU Medicine, which is our clinical entity, we are able to travel to all 55 counties of the state and be able to provide screening mammograms. At its inception, we made the commitment that no one over the age of 40 would be turned away if they were unable to pay. And we've, through the years, paid for these either through philanthropic dollars or through grants. Now it is a 45-foot state-of-the-art mobile unit that truly travels the state. We place it in very small rural communities and federally qualified healthcare facilities. You take that past history and our experience, and then you bring in lung cancer into the state of West Virginia conversation. So it is the second most common cancer, and it represents about 18% of the cancers that we diagnose, which translates roughly into about 2,000 people diagnosed annually. And we lose about 1,100 patients to lung cancer each year. Just as was previously mentioned, the vast majority of lung cancers are diagnosed at a much later stage, and 50% being metastatic, which translates into a much lower 5-year survival. Given that smoking is linked to 80 to 90% of lung cancers, it also provides us an opportunity to be an educational platform for those that present to the bus itself. West Virginia has the highest smoking incidence in the United States, and it has the second highest incidence of lung cancer in the United States. So it presents an area where we have a tremendous amount of potential impact. So what does lung cancer screening look like now in West Virginia? So we are, again, a rural state. You can tell the interstate system is not robust within our state, and each of those yellow marks represents an ACR certified lung cancer screening site that is stationary. And it's certainly clustered in certain counties while leaving a lot of other counties without any access. These numbers that you see, at least 200,000 unscreened, as well as 4% of the population, actually represent statistics that we did prior to the U.S. Preventative Task Force reducing the age from 55 to 50 and pack year history from 30 down to 20. So 4% is probably an overestimation, and 200,000 is an underestimation on how many people we have the potential to impact. There was quite a bit of formative work that was done prior to rolling out Lucas, which is our mobile unit. And as you can see, we started about 5 years ago. And part of that early work was understanding the knowledge that providers and communities have about lung cancer and lung cancer screening. And then once we understood that there was a buy-in, in the sense that there was interest in doing this from community partners, we then began an education that happened so that we not only educated the providers, we also started educating the community. And then only after all of those components were put together were we able to really get Lucas up and running. So this is a graphic of sort of all of the components as we were putting Lucas together and adding it into our mobile program, other mobile program. We started to detail where all of the needs and what we would have to accomplish. And as you can see, while equipment is a substantial portion of it, it really only represents a small amount. And we have to be better communicators, both with our community as well as with the public and the donors. And then also understanding what partnerships were necessary in order to be able to make this a very successful program. So this is Lucas. Lucas is an acronym for lung cancer screening. It is a fully independently powered mobile unit with AI technology, and it is the first in the nation. When we were building this unit, it was clear that other mobile units in the US took a CT scanner to a facility, plugged it into usually a hospital, and then scanned patients and then moved on to the next. Because our mobile program puts these devices and these modalities in very small communities, none of the places that we went to had sufficient power. So we also, not pictured here, pull behind this a very large generator that's pulled by a separate truck. And so when we go out, we can actually, truthfully, we could park anywhere, tap into the generator and begin lung cancer screening. On the inside of Lucas, you can see that there is a CT scanner, there's a control room. And so this is a fully functional 160 slice CT scan. We could put an injector on there and be able to scan patients from a variety of different scans, not just low dose CT for lung cancer screening. So once we had it all put together, we did a soft launch in September of 2021. So we were on the road for about 3 months. During that time, we scanned 168 patients in 26 screening sites in 22 of our 55 counties. We do pull our mobile programs off the road from December, late December into March, just to account for weather and road conditions. We kept the same commitment to not turn anyone away with Lucas as we did with Bonnie's Bus. And so of the 168 we screened, support funds that we had set aside through philanthropy as well as grants were paid by those mechanisms as opposed to by the patients or their insurance companies. In that soft launch, we were able to actually already identify 2 cancers, and we had a callback rate that was quite substantial at 18%. On the right of your screen, it represents how these 168 fell out from the lung RADs. And so for traditionally ACR would say for lung RADs 1 and 2, they estimate the population, about 90% of the population should fall into those 2 categories. And for us, and truthfully, in a small population, we only had about 82%. And the distribution of probably benign to suspicious and so forth, those numbers were anywhere from 2 to 3 times what was estimated to be in the general population. And so for me, this feels good. This tells me that we're getting to the places that we need to get, that we're getting to the populations that are underrepresented in general healthcare and that have difficulty accessing care in, overall. So what does it take to implement a mobile program like this? Well, there's quite a bit of startup costs, as you can imagine. So we allotted about $2.5 million for the initial purchase of the equipment and then the first year expenses. Other parts of this are personnel. And you can see the direct patient care actually happens with the 3 men up top. This is Eric, he's our CT tech who runs the scanner. And then these are our drivers. Not only do they drive the unit, but they also they are the intake for the patients that come to be screened. And I can tell you there's a profound sense of ownership amongst those 3 in this program. Others pictured here are behind the scenes staff, so the people orchestrating the placement and the clinics. It's important to note that it's the actual clinics that identify eligible patients. It's not us. I think it's very important when you're providing care into smaller communities that are very tight-knit that you come in and offer a service. You don't come in and force a service. And so that's where that community partnership becomes extraordinarily helpful as we move through this project. When you talk about return on investment, you can look at it from the standard profit and loss sheet. And in that sense, it probably will take us about 3 to 5 years to break even. If you layer in the downstream revenue of, in essence, the 2 cancers we've already diagnosed, or the other incidental findings that you get on these, such as cardiovascular disease, gallbladder, kidney, then that number shifts quite a bit. I think it's super important, though, to think outside of that box. And so when you look at the Harvard mobile healthcare map, they actually estimate that for every dollar you spend on prevention, you save $12 down the road. And that's obvious when you think about treatment of stage 3 or stage 4 lung cancers versus the cost of treatment of a stage 1 cancer. And then lastly, for me personally, because it's part of my mission here at the Cancer Institute, we actually catch people and give care to people that would otherwise probably never seek out care. And to me, that's probably the most important thing. And that's some of our intangibles of this mobile lung cancer program. It's also part of the intangibles of our mobile mammography. It's an investment in the health of our state. It's no secret in the United States that we have some of the least healthy patients and probably the oldest patient population, other than the population that's contrived because everybody moves to Florida to retire. And so we have to be very committed to taking care of our own. Lucas and Bonnie's bus are really a mobile billboard. For me, Lucas represents exactly what this cancer center is. It is a combination of education, prevention, early detection, and research. And so it is what we do here in Morgantown, just placed in smaller communities across our rural state. And with that, I really appreciate the opportunity to present what we have done here in Morgantown in West Virginia. Thank you so much for your attention.
Thank you very much. This was a very interesting talk. We move on to the next speaker, and we will have the discussion at the end of the session. Thank you very much, Professor Halser-Jenkins. It's an honor for me now to introduce the next speaker, which is Dr. Viteri. He is an oncologist from Spain. He was trained at the University of Navarra, worked for many, many years at the Dr. Russell Oncology Institute, specializing in molecular biology of cancer, personalized medicine, thoracic tumors, and clinical research. And he is now, as a clinical head, in charge of a team of 14 oncologists working in 4 hospitals in the area of Barcelona. And he will talk to us about the improving lung cancer screening, mobile CT, and liquid biopsy. It's yours.
Thank you very much for the kind introduction, and to the organizers for inviting me to this Oncology Days webinar. So as Professor Schaefer Prokop mentioned, I will be speaking about improving lung cancer screening with the tools of mobile CT and liquid biopsy. These are my disclosures. And well, when I was trying to address this topic, I was trying to pinpoint which are the major caveats that we are facing when we try to implement the lung cancer screening. Now that we know, as it has been previously eloquently explained, that the screening is saving lives because we are detecting early lung cancer that we can cure. And there are several points of difficulties that we must face. One, of course, as it has been mentioned, is the adherence of high-risk population. Unfortunately, lung cancer is associated with tobacco smoking, and tobacco smoking is still a very stigmatized condition. So some patients are afraid or ashamed and don't go or don't participate in the screening. So we need to remove the barriers, and we need to take make them easier to participate in the screening. And this is one of the major points where mobile CT can be helpful. Also, we need to optimize the population to be screened. So the same, in this case, I will explain you about a little pilot of mobile CT screening we did in an occupational risk population. I will show you in a while. And as it has been mentioned, we need to know what is the optimal screening interval and duration of the screening. We don't really know yet. And in that point, maybe liquid biopsy can be helpful. management of screen detected nodules. We know that we will, with the screening, we will identify several nodules, and we need to know how to handle them. And again, I think here liquid biopsy is helpful. And also we need to make the impact on quality of life the less as possible when we do our screening. So let's go to this. Well, here are the National Comprehensive Cancer Network guidelines. We oncologists use them quite a lot. It's a panel that evaluates all the evidence and tries to prepare these summarized and clear guidelines. And when it takes to lung cancer screening, you would see that they recommend to assess the risk of cancer by noting the smoking history, radon exposure, occupational exposure, personal cancer history, family history of lung cancer, other diseases, pulmonary diseases, etc., secondhand smoking. But when we try to classify and detect who are the patients that are candidates for the screening, we only take on account mainly the same as the inclusion criteria of the big trials, the age more than 50 years old and a history of more than 20 pack per year smoking. But probably we will need to personalize this much more. And these patients usually are recommended to go to do a low dose CT scan. This is the summary of our little pilot study we did. So it was a lung health check with a mobile ultra low dose CT in foundry workers in a little town in Tafalla. It's close to my hometown, to Pamplona, as you can see here in the map. We offered this screen to 150 workers in the Fagor factory, which is a foundry factory. They create parts of cars. And these workers are one of the most exposed to silica particles that I will show you now how they are linked with the risk of lung cancer and other diseases. And in collaboration with Canon and Institut Girado, which is a group of radiologists in Barcelona, the pilot used this mobile CT to compete with the regular screening that was done with regular X-ray in these workers. As I said, the problem with silica exposure is that when the dust with silica particles are inhaled into the lungs, they cause a triple damage to the epithelial cells. One is a direct cytotoxicity, the particles themselves damage and cause problems in the epithelial cells of the lung. But also there is an indirect toxicity related with the response of our body or immune system trying to get rid of the silica particles. When the macrophages do the phagocytosis of these particles, they also produce a big number of cytokines and chemokines and create an inflammation, a chronic inflammation that also causes an injury to the epithelial cells. So all these three kinds of damage, the direct cytotoxicity, the indirect cytotoxicity, and the chronic inflammation lead to genotoxicity, causing problems in the expression of the oncogenes and leading to tumor cells. This was demonstrated, and silica particles are now considered, well, since 1997, are considered carcinogen type 1. So as we said, this is the truck that ported the mobile CT to the factory, and the previous speaker has explained very well all the details. And this was the particular device that was used. In this case, the equipment was an Aquilion 1 Prime SP with AC technology and dose reduction. But the interesting thing here is that we didn't just use the low dose CT scan, but we used the ultra low dose CT scan. And let me show you how. This is the radiation exposure for different techniques. The regular X-ray is usually about 0.3 sievert, and the low dose CT scan is about 1.7 sievert. while the conventional CT chest can be even 8 sievert. And the natural background radiation that any person receives during 1 year of his normal life is around 2 sievert. So if you see this, you will realize that the ultra low dose CT chest has almost the same radiation exposure as a normal X-ray, and however, it can detect a higher number of lung abnormalities. The final results of our pilot study will be published in a couple of weeks, but I can share with you that it covered the objective where the ultra low dose CT chest scan was able to detect a higher proportion of lung abnormalities. Then let's go to the second part of my talk, which is around liquid biopsy. As many of you will know, liquid biopsy consists in trying to detect from peripheral blood different components that are produced in the tumor. So any person with a tumor, even if it is at an early stage, will shed to the blood circulating tumor cells, cell-free DNA, circulating RNA, or other components. And if we can detect these components, we may be able to use it for lung cancer screening and early diagnosis. And I will show you some examples here. One is in this particular trial that was a Scottish trial, which the idea in this case was using a blood test, a liquid biopsy, to decide which patients will need to go to the CT screening. So in this case, as you will see, they included 6,000 patients, and they were tested with an autoantibody blood test. I will show you now. And for those that were positive, meaning that they had a higher risk for lung cancer, they were included in a screening program. And those that were negative, we did normal clinical controls and only did CT scans when they had any symptoms. And here in the graph, you will see this is the number of detection of advanced stage 3 or 4 lung cancer. And as you can see in the intervention group, which is the yellow one, the objective was met because they were able to reduce the number of advanced lung cancer detected in the group when they applied this liquid biopsy first and then to select the patients for screening. Here is just a summary of how this liquid biopsy works. The normal cell has normal proteins, but the tumor cell has abnormal protein antigens, and this generates autoantibodies specific for tumor antigens. So what we can detect in the blood is antibodies against these tumor antigens. Then this is a second example, and this was associated with the MILD trial, the Italian screening that was explained before. But in this case, what they did is it was a different approach from the Scottish trial, because they were doing the CT scan for all the patients that were included, and then they did the liquid biopsy. In this case, it was a microRNA signature, and the main group, interesting group, is the CT negative. If a patient was CT negative but had a positive liquid biopsy, then this patient was allocated to a shorter interval for the next screening, meaning that those patients who were negative in the CT scan and in the liquid biopsy need to do the next round in 3 years. But those that were negative in the CT but positive in the liquid biopsy changed to the 1 year frequency. And in this case, they also were able to, the group with CT scan negative and liquid biopsy positive had a higher incidence and mortality of lung cancer as they were proposing. Here in the left, you will see the graphs where the in the above part, you see the incidence and the mortality of the lung from lung cancer with the basal CT scan. But in the lower part, you will see the same data, but removing those patients that had a lung cancer at the basal test. And finally, I want to share with you another approach we are working in liquid biopsy. This was our investigation in collaboration with Instituto Oncológico Rosell and Pangaya Oncology, where we are trying to create a 15 gene expression signature that help us to determine if a nodule, lung nodule that is found in the CT scan is benign or is cancer. And in the first 202 samples that we have analyzed, the accuracy of our signature is 80%. So with when we detect a nodule in the CT scan, we are able to confirm with the liquid biopsy if this is malignant or not, and help us to manage these nodules. And it is we will continue validating the signature, enrolling 300 patients with suspicious lung cancer. And lastly, to end, I just wanted to share with you this Cassandra trial that is a lung cancer screening trial that is going to start very soon in Spain, that will include 5,000 patients, smoker and ex-smokers. But the interesting point here, I think, is that it includes an intervention in smoking cessation and respiratory assessment at the moment of the screening. We do not only do the CT scan, but try to make the patients quit smoking and evaluate their pulmonary function. This is my team, and thank you very much.
Thank you very much for this very interesting talk. We will keep the questions, and it is my pleasure now to introduce the last speaker, which is Professor Prokop. He is radiologist, chairman of the Department of Radiology at the University in Nijmegen in the Netherlands. He's known as an expert for CT technology and advanced technology. And as such, he is a member of multiple industry advisory boards and scientific committees. He is fellow of the Society of Body CT and Magnetic Resonance and the current president of the Dutch Radiology Society. So please, Matthias, the floor is for you.
Thank you, everybody. Thank you, Cornelia. In this talk, I will look at the optimization of lung cancer screening by CT technology. Here are my disclosures. And I would like to go back to what Europe is doing at the moment. There is now this independent expert report on cancer screening in Europe. And one of the recommendations they give is to extend screening programs to lung cancer. And because lung cancer has provided a good harm-benefit ratio and cost efficiency. So that are the two areas that you have to focus on if you want to implement a good and successful screening program. You also know the benefits. Cornelia has already mentioned them. We get fewer deaths from lung cancer, about 20 to 25% fewer deaths in men, and up to 60% fewer deaths in women. But this effect wanes after a while. So after 10 years, that drops to half of that. And the benefits are only proven for high-risk smokers and ex-smokers. And as we have heard, we'd like to extend the benefits of lung cancer screening also to high-risk populations that are not covered in these inclusion criteria. There's a little problem, and that's the increased overall survival, which has been minimum in Nelson and LST. But as we have seen from trials that have continued scanning, not 3 times, but 4, 5, 6, 7, 8 times, we see that there is a survival benefit because the prevalent cancers have been removed, and then only the incident cancers are actually the ones that are relevant, and they can be detected earlier than with other techniques. And that means we finally also get an increased overall survival. Now, when you look at the technical solution and the requirements, how they interact, cost containment is, of course, one thing. A society would like to spend their money wisely, and cost containment for CT has to do mainly with optimizing the screening process itself. It has not been done very often, and many of the suggested techniques we've seen are not optimum for what I'm mentioning here, namely high throughput scanning. For high throughput scanning, you have to have a scanner with a simple interface, and ideally automatic selection of everything from scan range to automatic exposure control and reconstruction. And even better would be an in-room operation of scanners. At my former institution in Utrecht, where we performed the Nelson trial, we were able to perform 11 scans per hour, which really cuts down the costs massively, and I'll show you that in a moment. The second point is risk reduction due to radiation exposure. We've already heard that radiation can be minimized So also the risk for screening-induced cancers are minimized that way. And the crucial factors here are model-based iterative reconstruction, or more recently, deep learning reconstructions. Also what helps are silver filters that shape the beam so that the low energy radiation is filtered out and doesn't stay in the patient and doesn't contribute to the image. Finally, we would like to be able to identify our cancers increasingly early. And for that, we need, again, sharper, less noisy images. And again, deep learning reconstructions are really a key point here. That allows us to better assess malignant features and provide more precise and reproducible volume measurements. And the latter is important for better estimation of volume doubling times and aggressiveness. And that ultimately translates into fewer benign lesions that are found during our invasive workup, like biopsies or even resections. Now, when it comes to cost effectiveness, it all has to do with the stage shift towards earlier stages. It starts already at baselines, but it's much more pronounced after around 2 and 3. And here you see examples from the German LUCY trial, where you can see that the early cancers in the screening arm are rising much faster than the ones in the control arm. And as soon as you stop screening, you again do no longer find that many early cancers. Now, why is that important? Because if you find cancers early, the need for immunotherapy is reduced, and that is, at the moment, one of the most costly factors in healthcare. There's a calculation that shows exactly that. The effect for quality adjusted life years saved, lung screening in the United States would be $19,000. In the UK, 8,500. And what you see is that compared to these high value, high expense immunotherapies, lung screening is much, much less expensive. Now, I just mentioned that lung screening is really giving us the opportunity to scan really, really rapidly. And what I've done here is just a rough calculation, giving an investment cost of $1 million, depreciation, etc., all the same. The only difference is, instead of, let's say, 4 exams per hour, 50 minutes per case, we go up to 10 exams per hour. As I said, we've done it, and it's definitely possible. And by optimizing the workflow, we can also reduce the techs. And the 1.5 techs basically means there's 1 tech and a much cheaper helper that just puts the patient on the table and takes them off the table. And if you put that then together with a high throughput screening workstation, then the number of scans that can be read by a radiologist goes up to 10 and actually above. And with all these calculations, you can see that you can dramatically reduce the cost for a CT to less than 32 euros in this situation, but it's just a calculation example. But it shows there is a vast chance of cost reduction using high scanner throughput. I've already mentioned that reading is important. We've been working with Fraunhofer Mavis, a group in Germany, to build a high throughput workstation. And as you can see, this is, of course, a smoker, and filter cigarettes don't help because there is the ground glass lesion, which ultimately turned out to be a minimally invasive lung cancer. What is interesting that these high throughput workstations also work without radiologists. Here we did an experiment on the Canadian data using Canadian technologists and the CAD. And what you can see is that after about 100 cases, their time that they need to read these scans goes down to roughly 3.5 minutes. And if you compare to the cancers that are detected by this combination of the radiographer and the CAD, was 93%, which was actually higher than primarily seen by radiologists. So all of that is really possible. Now, radiation exposure, as I mentioned, is an important factor. And I think when it comes to ultra-low dose CT, we need better detector technology, which means higher gain or even photon counting detectors, stronger beam prefiltration. Canon is now experimenting with silver filters and iterative image reconstruction, or even better, as we will see, deep learning reconstruction. By that, we can really massively reduce the dose. And the critical areas are, of course, the lung top and ground glass lesions, where on a filter back projection is nothing. And on the iterative reconstruction, of course, you can see the lesion. Here is, again, a comparison of various lesions using filter back projection, classic hybrid iterative reconstruction, and then not filter back projection. That's basically the deep learning reconstruction and the the model-based iterative reconstruction. They are performing very similarly. If you use a silver filter, then the silver filter, just like thin filters, but even stronger, reduces the low part of the energy spectrum. And these low energy X-rays tend to stick in the patients much more and can tend to contribute less to the ultimate detector dose. So by doing that, we have a chance to even further reduce the dose required to get a good image quality. And we're now in the range with these ultra low dose scans of a flight from Europe to Japan. They're way, way below the lateral background radiation. Now, when it comes to optimizing nodule evaluation, we have to look at nodule volumetry, because that is one of the techniques that we're at the moment using for most precise measurement of nodules. One of the problems with volumetry is that the software is frequently not very precise, especially when the nodules are attached. And you can see in this old paper from Mr. Gittema that the variability is in the 20 to 25% range for the 95%, for covering 95% of all measured nodules. And it's actually not size dependent. That actually changes if you take only the well-segmented nodule, then it behaves much more benignly. And this is what we see on current scanners. We can see that there is, of course, a higher relative variability for smaller nodules and a lower variability for larger nodules. When I go back, you can see here the scale went from 40% to minus 40%. Here the scale goes from 15 to minus 15%. So the variability with modern scanners has been reduced quite massively, and especially ultra high resolution scanners provide even better reproducibility. Now, what does that mean? If you try to translate that in the ability to detect a volume doubling time of less than 400 days, which is usually used to cut off between malignant and benign, you have to wait at least 129 days to be reasonably sure that the nodule has this doubling time with this 25% repeatability. On those more modern scanners, this can be reduced to roughly a month. So there's a massive change in the accuracy of our malignancy prediction, actually the growth prediction and aggressiveness of these lesions. Here's an example how ACE, or deep learning reconstruction, actually changes the evaluation of a lesion. This is a hard solid lesion. Maybe it is also infectious bronchiolitis, not really. There seems to be some retraction of the bronchus, 1 millimeter section. And this is the same thing on an 0.5 millimeter deep learning reconstruction. And you can see that this looks much less benign and actually turned out to be an invasive adenocarcinoma. So morphologic evaluation using deep learning reconstruction and also higher resolution really helps us find features that we otherwise have not found. Here's a recent paper from Japan that shows that a solid core more than 8 millimeter is quite predictive of invasive adenocarcinoma, but also the disruption of the air bronchiogram, where you can see the bronchus is actually stenosed within the lesion. And you can see the arrowhead here, the black arrowhead, where you can see that the bronchus suddenly disappears and is occluded by the tumor. So to summarize, essential technologies are workflow automation with a good interface and ideally in-room operation. And Canon has worked quite a bit on that to optimize that, but we'll see other manufacturers working on that as well. On the scanner side, deep learning reconstruction is important The alternative is model-based iterative reconstruction, but that usually takes much longer to reconstruct and is much more computational. Expensive, stronger pre-filters removes unnecessary radiation, and low electronic noise by optimizing the detectors helps, and deep learning, and photon counting will be a really big step forward in that area. High spatial resolution is especially important when it comes to finding morphologic differentiators between benign and malignant. By doing all of that, I think we will be able to provide lung cancer screening of large groups of the population for a real bargain price with a very high likelihood of finding cancer without going into too many false positives and having to biopsy or bother patients with benign disease. Thank you for your attention.
Thank you very much, Matthias. I've collected some questions, and I think I will start with Professor Hazard-Jenkins. One question I think is quite interesting. You reported a high number of incidental findings, important incidental findings. How do you do that? Is there let's say a level, what you report, what you not report, what is clinically important? Are there any regulations for that?
So it's a great point. The part of this is the community partnership. So nobody in Morgantown here is the ordering physician. It's all the local providers that are ordering those scans. What we do provide is personnel that help navigate and make sure these incidental findings have made their way back to the provider, and then offer opportunity for those things to be worked up, whether it's locally or it's up here at the larger institution. So there are navigators locally within the clinic, but then we also acknowledge them and then follow up to make sure that whatever recommendations that were made at the original CT scan have been done.
Thank you. One question referred also to the amount of financial investment, and you mentioned some numbers. And is this just for the technical part or for the whole network? Just to give an order of what has to be invested.
So the number that I had quoted was for the purchase of the equipment as well as the first year service contracts and personnel. So there will be additional expenses, obviously, beyond that as we move through that process. But that was about what we spent to get it up and running for the first year.
Thank you.
Thank you.
I would like to move on to Dr. Viteri. And there had been a question from the audience, whether you also target other types of cancers or only lung cancer.
Yes, thank you. In fact, liquid biopsy is already in use for metastatic cancers. We use it a lot in lung cancer to detect the mutations that can be targetable, for example, and also is used in colon cancer or melanoma. But the new horizon here is trying to make the liquid biopsies useful in early disease or in lung cancer screening. So I know there has been a lot of research in prostate cancer and colon cancer regarding these early stages with liquid biopsy.
Thank you. Another question was, what is the difference between the SUMMIT trial in the UK and what you are doing, or what you reported? The SUMMIT trial is also using liquid biopsy and the combination with low dose. I have to admit that I'm not aware of any results yet, I have to say. So I think there is certainly some overlap, and there is certainly also the same idea of combining the information of liquid biopsy and CT. Yes. I'm not aware if somebody of the panelists know some results already, they may jump in. I am not aware of already some results. Matthias, do you know some? No. So, Dr. Viteri.
Yes, thank you. I think that the complementarity of liquid biopsy and image screening is very exciting. I think it's interesting because we can get more information, the molecular information linked to the image information. I think that there are different approaches we can try. As we've seen in the Scottish trial, what they do is they do the liquid biopsy first, and then those that are positive, they do the CT scanning. And the other way around is also being used, as in the MILE trial, where they did the liquid biopsy in all the patients that were in the screening, and then they tried to use this information to decide the interval of the screening. And for example, our own experience, where what we do is whenever we find nodules, then we do the liquid biopsy, trying to help the clinicians to decide if this nodule has to undergo a biopsy. So I think that there is a wide variety of uses where liquid biopsy can be. Of course, I don't think is any close or in the future that we can replace anything with just the liquid biopsy. This is not helpful. There are many caveats with the liquid biopsy I didn't mention. For example, one is called clonal hematopoiesis, which means that we can sometimes find in healthy persons, we can find abnormalities in the plasma that may confuse us, etc. So, of course, there are a lot of false negative results because we need to improve the sensitivity and specificity of this technique.
Yeah.
But the interesting thing is that it's a minimally invasive test, and it can be an ancillary test with the screening.
Yeah. Thank you. I have a question for Matthias. There has been a question in the auditorium. What do you think, why so many countries, especially in Europe, have not yet taken up screening? Is this for economical reasons? Is this for political reasons? Why?
I think that a lot of the countries actually want to do it well. And that basically means they would like to make sure that the money they're spent on screening gives you a good return on investment in terms of population health. For breast cancer screening, we know that we reduce breast cancer-related death, but not so much death as such. In lung cancer screening so far, only lung cancer-related death reduction has been shown, and it had mainly been shown in smokers. And there is still this discussion ongoing whether it is fair to offer screening, so potential salvation from cancer, only to smokers and not provide also some form of screening or help to the non-smoking population. So techniques that add, let's say, liquid biopsies for selection of patients, maybe patients that have increased inflammatory biomarkers in their blood, would be a technique that could help. So there's large grants going on or being active at the moment where Europe tries to figure out how to do screening better. And we can be pretty sure once they start it, it will be real mass screening. So I think it's a little bit different from the screening in the US, where it is on an individual basis. I think that we're going to go for real mass screening, and the UK is actually starting with that and is taking really big steps in doing that. Croatia, Poland are also following in. We'll probably soon see Germany joining as well. Everything has been prepared there so that we can start it in the next 1 or 2 years. So a lot of countries are thinking about it. Some are still hesitant because of the reasons I gave.
Thank you. I have a question for Professor Hazard-Jenkins again. Do you also include a smoking cessation program? And one question was, how do you handle the short-term follow-up, the 3-month follow-up? Is the bus returning, or how do you do that?
So those are great questions. The bus actually has lung cancer cessation information and education on it. So it becomes a early detection, but also a educational platform. And yes, unlike our mobile mammography unit, which only usually goes to communities once a year, Lucas does actually go back to the same communities for some of those repeat scans.
Thank you. There was one question, I think this was referring to my own talk, why adenocarcinomas have a better prognosis. I think, first, the highest frequency are adenocarcinomas presenting as adenocarcinomas. The group of adenocarcinomas is a very heterogeneous group. And they include also these very slowly growing, less aggressive tumors as compared to a more aggressive tumor of a squamous cell carcinoma, of a small cell carcinoma. And these especially low aggressive tumors are more frequently seen in women. So that definitely also plays a role. We are talking about subsolid lesions and so on, why the benefit is larger for women than for men. The preclinical course of adenocarcinomas is much longer than for squamous cell carcinomas of small cell carcinomas. So I think is there one big urgent question? I'm checking. Oh yeah, I have a very good and I think important last question. Will artificial intelligence play a big role? And I give that to Matthias. He is really into artificial intelligence. Matthias, you will have the word.
Okay, so the answer is very simple, yes.
Yeah, but how? Please explain.
And there will be a point. At the moment, artificial intelligence, as I mentioned, can help us really speed up interpretation quite rapidly and quite massively, so that we could even be able to scan a person and 10 minutes later, they can go away with their results. That's already possible now. But I expect the systems to really improve so much that there will come a time when they can be totally autonomous, which means that they will probably start with being autonomous for the easy cases, and then later also for more difficult ones. So what is important for AI then to be able to identify cases where it doesn't really know what to do, and then refer that back to a radiologist in the immediate stage. In the final stage, that's not the case. And that, of course, would cut down the total cost of screening by CT even more.
Yeah. Thank you very much. I see a lot of thank you very much, and very interesting. And with this, I give the word back to our host.
Thank you, Professor Schever-Prokop. That brings us to the end of day 3. I'd like to thank again our speakers and moderator, Dr. Hannah Heese-Jenkins, Dr. Santiago Kiteri, Professor Matthias Prokop, and Professor Cornelia Schever-Prokop. Excellent presentations, very interesting, and also thank you for all the really interesting discussions. I hope to see all of you again next week on Wednesday evening, when we continue the Oncology Days webinars with a session on kidney cancer. Thank you all for joining, and see you next week.